Good evening. My name is Arnita Varnado Jones, and I'd like to thank each of you for joining us tonight as we discuss issues of women's health. I am your moderator tonight for the Pink Table Talk. It is an honor to moderate this event, which is brought to you by Iota Lambda Omega chapter of Alpha Kappa Alpha Sorority Incorporated, located in Columbia, Maryland. This is Alpha Kappa Alpha's International Target 1 Health and Wellness Impact Day, and is done in honor of Breast Cancer Awareness Month. Breast cancer awareness and prevention focuses specifically on early detection through mammograms to improve the survival rate of women diagnosed with breast cancer. And Alpha Kappa Alpha has its own digital, AKA mobile breast cancer screening unit that travels to various locations and provide mammogram screenings. And we most recently were at Morgan State University and Howard University, where we provided over 75 mammograms in 2 days. We are committed to making an impact with our mobile mammography unit. The order of the event will be as follows. I will provide you a brief bio of each of the panelists around this table. We will have a short video. This will be a conversational talk around this virtual table. Audience, if you have any questions, please place them in the chat. We have people who will be monitoring it. So let's get ready for this Pink Table Talk. We have two esteemed guests starting out tonight for this event. Dr. Michelle Townsend Day is chairman of the Department of Radiology and chief of breast imaging at MedStar Union Memorial and Good Samaritan Hospitals in Baltimore, Maryland. She earned her medical degree from Louisiana State University Health Sciences Center in New Orleans, Louisiana. After her training in diagnostic radiology residency at Bridgeport Hospital in Bridgeport, Connecticut, Dr. Day obtained additional fellowship training in breast and body imaging at the Memorial Sloan Kettering Cancer Center in New York. Following fellowship, Dr. Day joined the faculty at the University of Connecticut School of Medicine as the director of breast imaging and was most recently a faculty member of the University of Maryland School of Medicine. Dr. Day has participated in numerous breast cancer symposiums, some of which were breast health disparities in the era of COVID-19, screening mammography, screening breast imaging, just to name a few. Dr. Day is a member of Iota Lambda Omega chapter, Alpha Kappa Alpha Sorority Incorporated. Welcome, Dr. Day. We also have on our panel, Dr. Regina Hampton. Dr. Hampton is the medical director of the Breast Care Center at Luminous Health, DCMC, the first breast center in Prince George's County. She is a board certified general surgeon who has focused her practice on breast health and breast cancer. Her former private practice, Signature Breast Care, was the first breast surgery practice in the county. Dr. Regina Hampton is also the medical director and co-founder of Breast Care for Washington, a nonprofit dedicated to providing access to mammograms, regardless of the ability to pay. The facility is the first 3D mammography facility east of the Anacostia in Ward 8, which has the highest mortality rate for breast cancer in the District of Columbia. She plays an active role at Doctors Community Medical Center. She's the past president of the medical staff, the first female president in the 40-year history of the hospital. Dr. Hampton was the project director for the Susan G. Komen $1 million grant that provided mammograms for uninsured women. Dr. Hampton attended Medical College of Pennsylvania and completed general surgery residency at Howard University Hospital. She is the co-founder of Cherry Blossom Intimates at Woodmore Town. It is a bra boutique offering custom prosthetics for breast cancer survivors and undergarments for all body shapes, sizes, and ages. Dr. Hampton is a member of Delta Sigma Theta Sorority Incorporated and the Links. Welcome, Dr. Hampton. Ladies, these are some serious credentials, and I am so excited to have you around this ILO virtual pink table tonight. So we're just going to jump right on in. Now, Dr. Hampton, I believe you have a video that you'd like to show us tonight from
Yes.
the Cherry Blossom Intimates Boutique.
Yes, thank you so much for having me. I'm so excited and looking forward to the conversation. So I will share my screen. All right, so we're going to just walk through Cherry Blossom. I know we're in a virtual environment, but we're going to all act like we're walking right through. What you see there is a pink wall that is actually a living moss wall. You can see we have a lot of just different beautiful lingerie. Our goal was to take care of any woman, no matter her body type, shape, or size. You can see as you walk here towards the back, and I'm going to actually stop it here because these pictures are very special. There's a picture of one of your sorors, Dana Walker, who was a childhood friend of mine that I had the honor of being able to take care of. And so her journey, she lost her battle to her journey. But what you're looking at here are the actual cells from when I did her surgery. And so we decided to honor her by taking something ugly and turning it into something beautiful. And we use it to really remind everybody to do their breast self-exam, to get their mammograms. It just gives us an opportunity to really talk about breast health on a daily basis, which I know Dr. Day agrees is so important, especially for women of color. What you're looking at here is one of our fitting rooms. We have trained fitters who fit everyone. We're not one of those places where you just come and grab something off the rack, because we want you to walk out with the right size, looking cute and feeling confident. We have a waiting area because we are considered a medical facility. So what you're looking at here is our waiting area. And so we want the ladies to be comfortable as they're waiting for their fitting, or sometimes the gentlemen are coming in with them. So we want them to have a place where they can relax while they're waiting for their lady to come out in something special.
Oh my goodness. I actually love that video. You know, if women have breast cancer or they have to have a mastectomy, there's a place in the community that they can go to where they feel comfortable in shopping and either coming in with their spouses or their significant loved ones, and just to make sure that they feel beautiful. And I just love that. I want to go back a little bit. Dr. Townsend Day, we're going to go back, and I want to know that I know a lot of women do not know a lot about the history of mammography and why they should have it done. So can you shine some light on this and give us a little history of the screening, and also as it relates to women of color? Because according to the CDC, Black women have a higher rate of death from breast cancer than white women, and we need to narrow this gap.
So in the mid-90s, there was the advent of widespread screening mammography. And interestingly, while the mortality rates for Black and white women were about equal, once screening mammography started, the mortality rate decreased for white women more so markedly than it did for African-American women. So the question was, why? A lot of it is, it's a multifactorial situation, of course. But in the absence of controlling for physiologic factors such as a more aggressive tumor biology, as well as genetic predisposition, the access to quality screening mammography has been one of the key drivers in the decrease of mortality for white women. So it is thought that if we can get more women to actually get our annual screening mammograms, then we can close that gap, controlling for all other factors.
Wow, wow. So, Dr. Hampton, as a board certified general surgeon, I know that you have a focus on breast health and breast cancer. So if I come in there and I said, well, I've been told I have breast cancer, how would you treat me? How is it treated for us?
So, breast cancer has just changed over the years. And what I often tell women when they come in is say, forget what you knew about breast cancer 5 years ago, because it's ever changing. Dr. Day and I, we have to stay on top of it, going to meetings, because there's always something new that comes out. And that benefits the patient. So it really is now a patient-centered approach. One size does not fit all. And we really tailor the treatment based on the type of tumor, the size of the tumor, the biology of the tumor, and what that particular woman wants to do. So 30 years ago, everybody got a mastectomy, everybody probably got chemotherapy, everybody got radiation, and then after 1980, some people were able to get hormonal medications. And so we really just take a very personalized approach. And COVID has made us switch that again. And so it really depends on what we're treating, would be based on how we would counsel you on your treatment.
You said something about hormonal medication. For myself, I don't believe that I would be able to take a hormonal medication. Could you explain to people why? I know I have in my family, my mother has had breast cancer. My two sisters have had breast cancer multiple times. And so I'm the one that they worry about the most. So when it came down to different things, when they have the change in life and we start having hot flashes and whatever, and they were like, you can't take anything that's hormonal. And so I'd like to really know why.
So when we look at tumors, we not only want to know what's the size of the tumor, we also want to know, are these tumors that like to take in estrogen and progesterone, which are our two female hormones that make us fabulous women. And some tumors can take that hormone in and use that as food to grow. And that's what we call a hormone responsive or a hormone positive or an estrogen or progesterone positive tumor. When a woman has that type of tumor, then she's eligible for a hormone treatment. That is a hormone blocker that not blocks the woman's hormones, but it blocks any new tumor cells from having access to her hormones. And so we cut off its food supply so that once we've treated her, we put her on this medicine to try and decrease the risk of her cancer coming back and to decrease the risk of a new cancer forming. And this medicine works very well in those who are hormone positive, so well that the typical 5-year treatment now in select women is being offered for 10 years, which means that we're keeping more cancer away. Now, the flip side of that is for women who have a hormone negative, estrogen negative, progesterone negative, and there's a third marker called the HER2 protein, and that can be negative as well. So those are known as triple negative tumors: negative estrogen, negative progesterone, negative HER2. We can throw all the hormone at those tumors all we want to. They're just not going to react to the hormones. And so in those patients who are triple negative, usually the primary treatment for those patients is some form of chemotherapy. And in this day and age, we're either going to give the chemotherapy after we've done the surgery, but more commonly, we're starting to give it before we even do the surgery. And why do we do that? Because we want to shrink that tumor down. We want to see how that tumor is going to react, because if it doesn't react to the chemotherapy, that allows us to be able to switch course and add different medications. The good thing is the majority of these ladies will have a response. So after that treatment's done, we send them to Dr. Day. She does a mammogram and an MRI and sends us a report that says there's nothing left but the clip. And then we get excited. We go in and do the surgery. And really all we're doing is taking the clip out, which is really awesome. So, I think for me personally, I don't think triple negative is as bad as it used to be. And I think that's just because the medications are a lot better. We know a lot more. And so we're just as aggressive as that tumor is. And we jump right on in there and we handle it and take care of it. I'll share a story. I just treated my office manager. And she had like a 2 centimeter triple negative tumor. We scanned her afterwards. When I did her surgery, there was not even one cancer cell left, not one. She had a complete, what we call a complete pathologic response to the chemotherapy. So in that respect, we've got to give chemotherapy some credit because it's saving lives.
That's awesome. So you said something about with Dr. Day. Can you explain the difference between mammography and MRI? And do you also have ultrasounds? I'm just trying to find out a little bit about that.
So mammography is the gold standard for screening for breast cancer. For high-risk women, we now have different tools to find more breast cancer, and those are breast MRI as well as breast ultrasound. Breast MRI is used in a small percentage of the population, those patients who have a greater than 20 to 25% lifetime risk of breast cancer overall. That test works very well in those patients in order to screen for breast cancer. We also use MRI, as Dr. Hampton had said previously, for patients who get medicine before their surgery. That will show the breast surgeon that how well the tumor did respond to the chemotherapy, and they can switch course if necessary. Breast ultrasound we do use in dense breasts. It can find more cancers than mammography can, about 3 to 4 more cancers per 1,000 women. It's very sensitive, meaning it finds a lot of things, but not necessarily specific, meaning that we'll find a lot of things that are not necessarily cancer. And because we're not sure, sometimes we do more biopsies, which can add to patients a little bit of anxiety and being unsettled. But breast MRI and breast ultrasounds are high risk screening tools that we do use to find more cancers. For patients with greater than 20-25% lifetime risk, we typically recommend MRI. For those patients who have dense breasts, we typically will recommend ultrasound for that patient population.
Wow. I wanted to remind our audience that if you have any questions, please put them in the chat. Also, when you said something about the mammography, is there a risk of screening? Because some people don't go and get it because they think there's this risk, and we're trying to find out what the risk level is for that.
Well, interestingly, the risks as have been stated in the literature are the anxiety of getting a recall, because no one wants to get called back, and understandably, because it is anxiety provoking. So that's been described as a risk. I mean, another risk is a mammographer calling you back for additional views and you actually having to get a biopsy. That's also considered a different risk, another risk. And interestingly, it's one of those risks that, if borne out in the literature, more women would rather undergo the anxiety, if you will, of getting the mammogram and or getting a biopsy and knowing they don't have an issue, as opposed to just kind of like not ignoring the fact that this actually could happen.
Okay. Wow. Wow. I'm going to ask, are there any questions in the chat?
At this time, there are no questions in the chat.
All right. Thank you. Let's go back. Dr. Hampton. Okay, so someone has breast cancer, they find out they've had it, they have it, and I want to know, what is the importance of a care team and their second opinions that they may want to get?
Yeah, so breast cancer care has really led the model in all of cancer care in creating the team-based model. So in the larger institutions, we all meet as a team, meaning once a week, some places every other week. We all sit at the table the surgeon, the radiologist, the pathologist, the medical oncologist, the radiation doctor, and the navigator, the nurse navigator, or the navigators are quite important as well. And we sit and discuss the cases. The radiologist will put up the images and
think she's cutting out a little bit.
A little bit.
Yeah, she'll be coming back in a
of the
second.
discussion, we're all coming together as one. So that when we go to speak to the patient, we're all saying the same thing, and not like the surgeon saying this and then the oncologist is saying this. We're all singing from the same songbook, so that the patient is hearing the same information heard from different providers. And some of us have different ways of communicating that information, but we all work together as a team. And I think that really has made the difference. 20 years ago, a woman was given a diagnosis and she was given the yellow pages and said, go find a surgeon. Well,
Yeah,
she probably didn't even know what a surgeon was. And so overwhelming. And so it's really about us using the navigators and really holding that woman's hand and walking her through that process. When she needs additional images, we'll help her to make that appointment. So we just really want this to be easy. I always just tell the patients, let us do the hard work. We know how to do it. We do it every day. You focus on healing.
okay. That's one thing I was thinking about, when you were saying that about, we do need to focus on healing, on what's going on, and we need to kind of guide people. I believe there are some questions in the chat. I can see some, so let me see if I can pull up and see what it is.
So Arnita, Arnita, I do have the questions for you. I did
Thank
ask for
you.
some clarification on the first one. And the first question is, states that Dr. Hampton mentioned the clip was left after the hormonal or chemo treatment. Can she explain a little bit more about the clip?
Actually, Dr. Day, do you want to?
Thank you. So when we biopsy our patients, we leave a little marker clip, and it's the size of a tip of a pen. So it's an X marks the spot. So if follow-up surgery needs to be performed, we know where we were. And so in cases where the patient has a high risk lesion, which is not necessarily cancer or cancer, we refer to our breast surgeon, and the breast surgeon knows exactly what to take out because it's demarcated by the clip, which hopefully matches the mass or the area of interest.
So this clip, is this something that's going to hurt?
No, it's made
Okay.
primarily titanium. It's very small.
Okay.
And if you do not need any subsequent or any follow-up surgery, it's not a problem. You can go through metal detectors. You can get MRIs. It's not a problem.
Thank you. Thank you.
Thank you, Dr. Day. And Arnita, there are a couple more questions. So,
Go ahead.
okay, so we'll go ahead and go with the next one. The question states, can you request an ultrasound for dense breast tissue? They used to give this person one in addition to mammogram. Now they don't, but still add the dense tissue as a disclaimer.
Yes. So in the state of Maryland, we are required to put a dense breast notification in all mammography letters. And so depending on the density of your breasts, it'll say scattered. It'll basically say either fatty or dense. Let me share my screen. And when we're talking about dense breast tissue, we're talking about the relativity of tissue relative to the amount of fat in the breast. And so when I talk to patients, I like to kind of give the example of a sky. So the blue sky is the fat in your breast, which is down here is black, and the white clouds are your breast tissue. So the cloudier you are, the denser your breast is. And the challenge of the whole thing is the denser your breast is, the harder it is to find breast cancer, because while your breast tissue is dense and white, so is the cancer. So you can see in this patient who has a fatty breast, there is the cancer here, and you can see it very well because it's white showing up on a black background. But this patient here in the lower part of her breast has a cancer, and it is also white, but the majority of her breast is white. So it makes it more challenging to find breast cancer, which is why for those patients who have dense breasts, we do recommend ultrasound because it's more sensitive in those patients.
That's interesting. I want to say that I got my first letter when I moved here to Georgia this year. And I went to have my mammography, and I also had an MRI. And so I got the letter that said that I did not have dense breasts. So that's just really interesting to know that. Are there any other questions?
Yes, there's a couple more questions. The next one states, is consuming alcohol and caffeinated beverages a myth or a fact to increasing malignant tumor?
Ooh, who's gonna take that one?
So, so let's take alcohol first.
Okay.
So they recommend drinking alcohol in moderation, no more than a glass a day, and in fact, consuming larger amounts of alcohol can put you at increased risk. Although there's the balance of, if it's good red wine, the cardiologists are saying it's good for your heart. So we've got to balance that out a little bit. And then when we talk about caffeinated beverages, that comes into play not with breast cancer, but with something called fibrocystic changes. And so fibrocystic changes is something all of us have. It's really just normal breast tissue. And our breast tissue is going to react to our hormone levels. Some women can react to caffeinated beverages. So when they drink large amounts of caffeine, chocolate, tea, soda, they get more of these items in the breast called cysts, which are just fluid-filled pockets. But for some women, they can get a lot of them. And I know Dr. Day gets those breasts that are very cystic-y, and they're not dangerous. It can make it harder to detect something that's going on, but having cystic changes in the breast doesn't put you at any increased risk for breast cancer. I think the two biggest risk factors for breast cancer are just being a woman and having breasts.
Wow. Okay. Next question.
There are three more questions that have popped up. The next one goes back to dense tissue, and I want to just bring that up. The person states that their question is because their mom is a breast cancer survivor, and they had to start mammograms at an early age. They have dense breasts, and every time they ask to have a 3D or an ultrasound, they find themselves fighting to be scheduled. Why is that an issue?
Interesting. So this is a good topic to speak about high-risk screening. The American College of Radiology and the Society of Breast Imaging recommended beginning in 2018 a risk assessment beginning at the age of 30, so that those patients who are at increased risk can begin supplemental breast imaging, which would include MRI preferentially and/or ultrasound. I'm not quite sure why it would be difficult to schedule the 3D mammogram, because that should just be a given. Most centers in Maryland should be performing 3D mammograms, and if not 3D, at least 2D digital mammography. The subsequent, now for MRI and breast ultrasound, those are different, and that's going to be dependent upon the actual mammography report. So you'd have to have the one prior to getting the other two ancillary imaging studies. But scheduling a 3D mammogram should not be a problem in the state of Maryland.
So you said something about they're starting at the age of 30 now. Do you know when they started, what age they started at prior to that for having mammograms?
So it depends. So typically, classically, we recommended that we start screening 10 years younger than the family member that had the breast cancer. So for example, if your mom was diagnosed with premenopausal breast cancer beginning at the age of 40, we would recommend screening at the age of 30. We at no point recommended mammography younger than the age of 25 because of the density of the mammogram, because of the patient's age, and the radiosensitivity of the breast tissue at that young age. So high-risk screening for high-risk patients was typically mammography and MRI, not beginning before the age of 25.
Okay. I asked that question because I started early, but during that time, I probably was 27 when my mother had breast cancer. And so during that time, I had to pay all of the whole time that I had it based on her and then my sister's getting it. So I was just wondering when the time frame was of when it does. So 10 years after or 10 years before.
10 years before the youngest family member.
Wonderful, wonderful.
And I'll also just add, if women think that they're at significant risk because of family history and you're having a fight, get enrolled in a high risk program. So most of the breast centers in the area have a high risk program where we follow women who don't have breast cancer. And so we'll run a risk assessment, see what their actual risk is, and based on the number, if it's greater than 20%, then we'll send them for additional studies like an MRI. But we will keep an eye on those women very closely. So, and usually with us ordering it and the way we order it, it probably also depends on how your provider is ordering the imaging as well. And be sure to give all the history. So I think that's a good way. We should be talking about family history. And I know typically in, African American and Latino families, we don't talk about our history, but this is where history makes a difference. We want to know that mom or grandma was in her 40s or even in her 30s when she developed breast cancer, because then that will give us the ammunition we need to say to the insurance company, hey, we need to follow this young lady closely because of family history.
Yes. That you brought up something that when you said about what is it called? BRCA? The
BRCA?
The BRCA.
BRCA.
Yeah,
BRCA.
BRCA. Could you talk a little bit about BRCA?
Yeah, so BRCA, which is also known as the breast cancer gene, there's BRCA1 and 2, and those put women at significant risk for breast and or ovarian cancer. So for women who are positive for the BRCA gene, they are at almost a 90% risk of getting breast cancer. And what I tell those patients is, look, you're going to get it. I just can't predict when you're going to get it. And not only are they at risk for that one breast cancer, they're at a 65% risk for a second breast cancer. And so, Angelina Jolie is one of the most popular people out there who's a BRCA mutation carrier, and everybody asked why she had her breasts off. Well, she was 90% risk and 65%. I think, there's just no question. And along with that, she was at a 45% risk of ovarian cancer. And it turns out the ovarian cancer is actually more dangerous than the breast cancer because we can screen, we've got very good screening modalities, but the ovarian cancer is very hard to detect. And so there are specific guidelines on who can get tested. They've started to open those up more and more and more. The most recent change is for triple negative patients. It used to be you had to be triple negative and diagnosed under the age of 60. Now the guidelines just recently changed. If you had triple negative at no matter what age, it doesn't matter when you had it, you need to contact a provider to get tested because that information could be important not only for your future risk, but also for the risk of your family.
So it's only looking at that particular person's gene. It's not looking at the actual family member or as a comparison, is what you're saying.
Well, it is. And typically, when I counsel patients, I say, if the person who had breast cancer can be tested, that's who we ideally want to test. Mm-hmm. Now, if that family member is not available, then we'll test whoever is available. But it's really kind of putting all those pieces of the puzzle together. And we've even started to increase the number of genes because there are more genes now beyond the BRCA gene that can be related to breast cancer. And so there's some gene panels that have like 100 genes on them. Which I think is great because I think, certainly for me, I diagnose and treat a lot of African American and Latina women who have some strong family histories, but they're BRCA negative. And so in my mind, there's got to be another gene out there. And so we've got to just continue to test, especially those triple negative patients. I've treated a lot of triple negative. When those patients come in, I'm now getting them tested, and we're even trying to contact them to get tested to see, can we pick up some more of these gene mutations and make some more differences in people's lives?
So I'm going to throw another twist in here. So you said if that person is available to be tested and they have had breast cancer on several occasions, but they do not carry the gene. So you're saying that there could be another gene that they're carrying that we just don't know about.
There could be. And I think that's where genetics is one of those that's just ever changing by the minute. they're discovering so much more information. So the good thing is that many of the genetic companies now are pooling their data so that when you get tested, it's going into a big pool, so that if they're finding these smaller unknown genes that start to become a pattern, then they can look at that, contact those folks, retest them, and see if maybe there might be a new definition and a new gene out there.
Okay, great. Are there any questions in the chat?
Yes, there are a couple questions, and there are some that have been associated with the genetics. So I think that they may have been covered off. So I'm going to ask the other three that are in the chat. I'm going to ask all three of them, panelists, if you could maybe take a stab at each one of them in the remaining minutes that we have.
Yes.
The first one, or the latter, I should say, because it relates to genetic testing, states, is there a genetic test your mom or dad can take to help the offspring for the future? The next two, is there a correlation between breast size and density or body type, BMI? And then the final one states, is there an equivalent risk for women whose father has prostate cancer and mother has a history of breast cancer than women whose mother and sister both have breast cancer? So in those two situations, they're equivalent.
I'm going to sit back on this one because I want to hear all of these answers.
Dr. Hampton, doesn't it, like remind you of like a problem like in medical school, like with the circles and the.
Wow, that circle over here and over there. Yeah, you go ahead.
I'm gonna take the breast size.
Okay.
So typically, this depends. So typically, larger breasted, in my experience on the number of mammograms that I've read, and Dr. Hampton can correct me, typically larger breasted postmenopausal women typically have more fatty breasts, meaning you see more blue sky and less clouds. Now, younger women with big breasts, because of their age and then they're typically smaller, you'll have dense fibrous tissue. So it kind of depends on age, and it depends on age. Now, with respect to weight, older women, so breast density is a function, as we've seen previously, about fat, which is the blue sky, and clouds, which is the dense tissue. As you get older, and depending on the amount of fat that you have in your body, you'll have apparent increase in your breast density because you have less fat. So a lot of factors affect breast density. Your BMI will affect breast density, as well as hormone replacement therapy, if you're on it, can also affect breast density.
Yeah, and gaining more weight after menopause is an increase, puts you at increased risk. And that's because the fat cells like to hold on to that estrogen. So that's something that we all need to be conscious of, is about how much weight we gain after menopause. Now, those genetic questions felt like that was a medical school.
Well, I know.
But good questions, very good questions. And I think in those cases, those were two very complex issues. I think in that case, I would refer you to a high-risk program and to a genetic counselor who can really sit and map out those squares and circles and map out family history to kind of see if they can see where the pattern is, and to determine, where the risk may be, and to also to calculate what your risk actually is.
You handled that well, both of you, because that was a mouthful. Are there any other questions?
Did we address the one about, is there a genetic test for mom or dad to take to help the offspring for the future? So future offspring?
Yeah, I would also refer that to like a high-risk program or to a genetic counselor, because it's really going to depend on like what's the history, what cancers are in that family, will make a difference on who gets tested, and the type of test that is offered, the type of genetic test that's offered.
Okay. And then the last question we have right now is, for those of us not receiving mammograms yet, what is the best measure of prevention?
I think learning your body. So doing your own self breast exam at this point in time would be the best prevention. And for those of you who are not mammogram age, but are at least the age between the ages of 25 and 30, getting that high risk assessment from your primary care physician is also a method of prevention.
Great.
And
Awesome.
then also along, the last question really at this time is, what should we be looking for in a care team?
I think you should look for your care team just like you shop for anything else. I think as women, we want that cute dress. We're going to get the best, price. We're going to make sure it's the right color, those shoes. We should shop for our doctors in the same way. You should interview your doctor. You should check and see, do I get a good vibe? Can I understand this person? Are they talking to me or are they talking down to me? Are they, not giving eye contact? I think all those things are important. Do they get, snippy when I ask questions? All those are factors. And if it just doesn't feel like a right fit, go get a second opinion. I have patients who say, well, I don't want you to be offended that I'm going to get a second opinion. And my thing is, I'm not offended. You have one body and you want to do everything that you can to take care of it. And this is not about me. This is not my journey. This is all about you. I know some great providers in my area. I'm happy to make the referral. I will have my navigator navigate you there so that you can get the answers that you need. And so, I think it's really about finding a provider who's just open with you. And there have been some times when I've had to fire a patient. So you can fire a doctor, doctors can fire patients. It goes both ways. And sometimes it is what it is. And that's okay. And everybody moves on and is happier for it. But, I think, we've got to be discriminating. We've got to ask questions. And I think one thing that women don't do is, I know sometimes women want to go through this journey by themselves, but it really helps to have an advocate for you, because when you're in that room, you don't know what to ask. Your mind is swimming. And I often tell my patients, I know you're looking at me like, who is this lady? Why is she giving me this news? I don't know, what's going on with her ear. You're thinking about everything else except what I'm telling you. And I get that. And so I've learned over the years to sort of give small snippets over a little longer period of time. The good thing about breast cancer, it's not going to go from a stage 0 to stage 4 in 1 week. It just doesn't happen that fast. So it's really important that you all as patients really take your time to get the information, to hear the information, because that's the only way that you're going to be able to really make good decisions and treatment decisions for yourself.
And
I like how you said about, we go out and we look for that dress and those shoes. We need to be doing the same thing that we do when we're looking for our providers or our care team, because we need to have that vibe with them. And that's definitely something.
And it's really important. I think that can't be understated, because I know a lot of people are like, we don't know the science behind it, right? But you do know when someone is there wanting to support you, wanting to make sure that you're okay, listening to the questions that you're asking, being responsive, having good office staff that are willing to call you back and, shepherd you through the process. So even though you don't know the science, you do know good people. And then there's also the internet. So you can look up the credentials of the breast care team on the internet. Hopefully you're all using that. The actual website that the actual hospital websites, so that you can look at the credentials to make sure that your providers, your physicians and the physician team are, board certified and credentialed. So those things being equal, the vibe is definitely important, because it's a process.
I want to get in another question. What are some of the clinical trials for breast cancer?
So there are a lot of them out there. I would refer you to the NIH, clinicaltrial.gov. And one thing I want to just mention about clinical trials, I just heard a great epidemiologist say this, and clinical trials is a big thing now. We're talking about vaccines and things, but not all clinical trials mean that you have to take a medicine or that we're going to give you something. There are a lot of clinical trials that are just observational, where you may have already gotten your treatment and we're just going to monitor you, check in on you, see how you're doing. I'm actually in a mammogram study where they're looking at mammograms and who should get them and how often. And I'm not taking a medication. So I think it's important to speak to your oncologist as well. Many of them are involved in clinical trials. A lot of the university-based hospitals will have clinical trials as well. But I think especially for Latino women, any woman of color, we have to get more active in clinical trials because, we think some of the medications may work differently on us. We're never going to figure that out if we don't get to be a part of the process.
Okay. And what is the survivorship of having breast cancer?
So for a stage 0 and a stage 1 breast cancer, the 5-year survival rates are 100%. I mean, we've just gotten that good, which I think is phenomenal. For stage 2, it's about 93%. And what I tell people is, even if you're diagnosed with a 3 or 4, get up and fight, because we're able to take a stage 3 patient and many times drop them down to a stage 0 or a stage 1. And a stage 4 patient, in many cases, we can just turn that into a chronic illness where stage 4 patients can live for years on maintenance therapy. So, I know not all cancers are like that, but breast cancer, I think we're winning. We're doing a great job, and realize it's not a one treatment fits all. Take your time to really explore all your options, know who your doctor is and your provider, and get good information.
Thank you. Ladies, I want each of you to give me your last words of what you would say about breast cancer or mammography or what needs to be done. Dr. Hampton?
So I think my internet kind of went out. I didn't hear the question. I'm sorry.
What are your last words that you would give to this audience today about breast cancer and what needs to be done?
I think adhere to your doctor's recommendations, know your body. If you get that call back, take a deep breath, go right back in and get the information. It doesn't mean anything bad is going on. And if you're diagnosed with breast cancer, put on the pink gloves, the pink shoes, the pink whatever. It could be any color, but put them on and start boxing and fighting the good fight so that you can be a survivor. You can be. There are millions of women out there who've survived breast cancer who look fabulous doing it. So you can do it too.
Wonderful. Dr. Day?
Get a risk factor assessment between the ages of 25 and 30 from your primary care physician. And for those patients who are at average risk, screening mammography beginning at the age of 40 saves the most lives from breast cancer. Get your mammogram.
Oh my goodness. This has been so informative, and I want to thank Dr. Regina Hampton and Dr. Michelle, Townsend Day for sitting around this virtual pink table, because it was a lot of good information. I think the younger generation says you gave us a lot of tea today. And this was just simply awesome, shedding light on what women need to be doing, what we need to do with our care teams, how we need to, know our care teams and what they're doing. So I'm just so excited. You are first part of this pink table. I have 3 more guests that have come in, and we're going to have next, we'll have on our pink table, we're going to have Ms. Leslie Hudson. She's the co-lead of the Power of Pink virtual walkathon sponsored by Iota Lambda Omega chapter of Alpha Kappa Alpha sorority. And she's going to introduce our next guest and make a presentation. Can't hear you.
Thank you, Arnita. That session was so informative, and I appreciate Dr. Hampton and Dr. Day. As for what I wanted to share is that for the last 49 years, The members of Iota Lambda Omega chapter of Alpha Kappa Alpha Sorority Incorporated, we have been partnering with other Howard County organizations that serve our residents. And this year, for Breast Cancer Awareness Month, we are hosting what we call our Power of Pink Walkathon to raise funds this year for the Claudia Mayer Tina Broccolino Cancer Resource Center. And so I am so thrilled that this evening, joining me from that center is Ms. Christina Miller and Ms. Lori Thorner, and they are going to share with us the resources. If you remember, the doctors shared with us, it's so important to have wraparound services that can, and people who can walk with you as you go through your journey. So welcome, Christina and Lori.
Thank you.
So share away. We want to hear what you have for us here in Howard County.
Well, I will tell you that panelists did such an amazing job setting up the transition from their talk to our services. We truly are a center for the entire community. There are no limitations to who can benefit from the services provided here at the Claudia Mayer Tina Broccolino Cancer Resource Center. I can tell you just a quick story. 9 years ago, I was diagnosed with stage 3 HER2 positive breast cancer. I was 39 years old and I didn't know where to turn. And I walked through the doors of the Claudia Mayer Tina Broccolino Cancer Resource Center, and I found the support that I needed, the information, the answers to the questions that I didn't know I had. And so 9 years later, I'm in a position now where I'm the manager of the center. And working alongside with Lori Thorner, we're here to support anyone diagnosed with any type of cancer. We do that through philanthropy. Our services are free. We have a wig salon, so that supports those patients that do have to go through chemotherapy and are experiencing hair loss. We have everything from donated wigs, so that would be free to a patient, or wigs that may be for purchase if they so choose to take that route. Our goal is to make patients and help patients feel empowered to walk their own individual journey through their cancer experience. We've been there, and we are here to help support family members and patients with resources that are available here locally and also in the larger community. I wanted to just say one last thing before I turn it over to Lori, because you can tell I have so much passion for this that I could probably talk to you for a half an hour, but I won't. I went to a grand opening of the Proton Center at the University of Maryland, 5 years ago. And Elijah Cummings was speaking, and he introduced the new Proton Center by saying, take your pain, turn it into passion, and turn your passion into purpose. And for me, that encompasses this center and what each of us is put here with a cancer experience to do for those people around us who are also diagnosed with cancer. We need to provide that hope and support to each other. So thank you, and I'll turn it over to Lori.
Thank you. Thank you. Just wanted to say I've learned so much this evening, even being in the field of oncology for a long, long time, from Dr. Day and Dr. Hampton, and thank you to the moderator. It's just been really uplifting and informative, as you said. But just to give you an idea, we get referrals to the Cancer Center from providers and in the community. And as Chris said, there's no barriers to the services at the Cancer Resource Center. Everything for psychological and emotional support is provided free of charge. And an example of some of those services are individual counseling, family counseling, and we have specifically for breast cancer survivors, a breast cancer support group, as well as other support groups and wellness services. An example of the wellness services are a mindfulness practices class and journaling practice class for patients and their caregivers to go deeper into their own reality about what it's like to live with cancer. And I myself, as well as Chris, am a breast cancer survivor. I was diagnosed in 2019. The doctors talked about hormone receptor positive. I was estrogen receptor positive and progesterone receptor positive. And later I discovered I have a genetic breast cancer in addition to that diagnosis. So while I've been working in oncology a long time, I've lived my own cancer journey. Additionally, I'll add that an example of what we do here is to be a part of your care team, as the doctors were talking about. So we are a part of your care team. And whether you're being referred through a provider or you're calling on your own to get help, we're following you from the point of diagnosis, new diagnosis, throughout active cancer treatment, throughout surgery, radiation, chemotherapy, hormonal therapy, as discussed. We're here by your side, providing the customized services that you need to be able to cope better and advocate for yourself in the healthcare system. Another thing that we pay attention to is healthcare services equity. And so we look at barriers that, especially breast cancer survivors in this situation, we're looking at barriers that could prevent women from accessing the services that they need for diagnosis and treatment and throughout their survivorship. So we offer healthcare navigation resources as well to the clients here at the center. And it's our honor to be able to be the recipient of your generosity.
Thank you. Before we move on, I just have to ask, some may want to know who were or who is Claudia Mayer and Tina Broccolino?
That's a great question.
Yeah.
So Claudia Mayer was a community member whose husband was a physician here at the hospital, and she passed away at the age of 47 from breast cancer. Her really good friend at the time is Tina Broccolino, who is still currently very active in developing the support services that we offer here at the center. And so the center was named after both of them in recognition of their desire for this community-based support services to remain here in Howard County.
Oh, wow.
Okay. Well, great. We are just excited that we are able to support your organization. So first, I want to just say thank you for the work that you're doing. I too am a breast cancer survivor, 2018, and it's been a journey, but I'm on the other side now, and never knew that I would be a part of that sisterhood, because it really is a sisterhood. But I just want to share with our viewers that we are only 4 days into our, of course, what we refer to is Breast Cancer Awareness Month. And besides just providing information to our community, we also want to put our resources into the community. So to date, we have raised $405.40 through our Pearl Foundation, but we are just getting started. This campaign runs to the end of October. So we will be presenting the full amount to you at the beginning of November. We are really pushing. Coming up later this weekend, we actually have our walkathon. It's semi-virtual because of Corona, but we are asking our viewers, we have dropped in the chat and in the link, it's on our Facebook page, on our website. where you can go to Eventbrite. We have 4 levels of giving. This is a great organization. You've heard the women, you've heard the doctors share the progress we made. And so we want to give back to your community. So Christina and Lori, we're just getting started. We're at $405, but I'm believing that we will have some. I know we will, because we've done other campaigns in the month of October. So it's really our pleasure, and you will be receiving that check from us the beginning of November, and I'm sure we'll be in the, at least the 4 digits of some as
That's
far as
fantastic.
donation to you. But
We're so grateful.
thank you for allowing
Thank
us
you.
to partner. You're welcome. And like I said, this is just the beginning. This is just October 4th. And it's, yes, I see it in the link where you can go. 4 levels of giving. So back to you, Arnita. And thank you, Lori and Christina.
Yes, thank you so much, Leslie. Thank you, Christina. Thank you, Lori. This is just this. We're going to bring it for you. We're going to help raise
Oh,
the
yeah.
money for this community. So we're coming on it, and we're counting on our people out there to do this. To my studio audience, I want to thank each of you for being in attendance at this webinar today. We have several resources that we'd like to provide to you. We will drop in the link, the National Breast Cancer Resource Guide. We also have a link in the chat for the evaluation. Please fill it out. And there's a link to the Eventbrite Power of Pink Breast Cancer Walkathon that we'd like you to contribute to. I want to thank you. So Linda, let's take this on home for all that you've done, and let's go head out in a bang right now. Thank you all for coming. And you all take care and have a wonderful week.